Today we have the Minnesota Legislative Session overview. We got Chad on from the Manager of State Legislative Affairs, Minnesota Medical Association. So again, thanks so much, Chad, for coming, and we'll get to the announcements and then to your slides. Next slide. There we go.
All right, so coming up next week, we have Minnesota Department of Health biomonitoring and emergency and contaminant supervisor. So kind of what's coming up, what they're noticing in all sorts of substances. And then I believe the week after, Kurt, you're doing your burnout presentation possibly. So
yep, we're going to be doing something on compassion and compassion fatigue. So it should be fun. That'll be on the 16th. Remember, there's free CME. Make sure that whatever Katie sends you, you fill it out and you'll get that back. And remember, please roll your video on because Chad would rather talk to your face than your name. So that would be great.
And then Chad, when you first start talking, if you want to just kind of let us know how you'd prefer to field questions, because we can keep track of the chat for you so you don't have to try to multitask. And then if you want us to interrupt you, if you want to wait till the end, just let us know. So
probably towards the end. Thanks for asking.
Perfect. Yeah, it's just sometimes people are okay with it and some it's easier. So if anyone has any kind of advice or questions or troubleshooting things or patient cases they want to reach out, you can reach out to Aaron or Kurt or I. There's our phone numbers, Aaron's cell phone, and email address as well.
And remember, you can go on the core website. All the information that we've kind of developed over the years is on there. Lots of different things to the current echoes and recorded sessions. So feel free to visit that also.
All right. And with that, we'll have the slides take down. Chad, you can use your own slides. And thank you so much. I'm just super grateful that Juliana was able to connect us. I know it kind of went through several of you. And so just so grateful. I know that it's hard to track everything that's going through the legislature all the time and it's confusing. And so to get the pertinent medical side, not that everything's not pertinent to all of us as citizens, but in the medical world, I think this is great. So greatly appreciate it.
Sure. Well, thanks for having me. I appreciate it. So I'll just get started here. So good afternoon, everyone. As mentioned, my name is Chad Fanning. I'm the Manager for State Legislative Affairs at the Minnesota Medical Association, the largest state medical association representing physicians. I spend a lot of my time at the Capitol in St. Paul during the legislative session. So what I'm going to do is offer a legislative overview that will touch on our legislative priorities from this past session, other items that passed, what didn't pass, and what to look for going ahead. It should be about 20 or 30 minutes. And then, as I mentioned, I'll have some times for questions and discussion at the end. So I thought it would help to offer a quick election recap from this last November midterms, even though to all of us that feels like forever ago. As you all know, DFL incumbent Governor Tim Walz was reelected to serve 4 more years in office. Minnesota reelected a DFL majority in the state house and flipped the Senate to give DFL control of the House, Senate, and governor's office, otherwise known as the trifecta. In Minnesota, there are 201 total legislative seats, 67 in the Senate, 134 in the House, with 2 House members for every senator. Last election, Minnesota voted in a lot of new legislators, 71 in fact. 57 of those are what we call in the biz true freshmen, having never served in either body before. Those other 14 legislators have served either a non-consecutive term or previously served in the other body. This is also the most diverse legislature Minnesota has ever seen. 35 members are people of color, and 76 women were elected to the legislature. 3 candidates became the first Black women to serve in the Senate, and we also saw the first trans person and first non-binary person ever elected to the Minnesota House. The MMA, we tracked, how many physicians are at the Capitol. So 3 physicians: Matt Klein, an internist; Kelly Morrison, an OBGYN; and Elise Mann, a family medicine doctor, were elected to the Senate last November. The legislature convened on January 3rd of this year and wrapped up its business on time on May 22nd. This session was the first half of the biennium, also known as a budget year. That means the legislature had a constitutional requirement to pass a statewide budget before the end of the fiscal year, which is exactly what they did. Deal holders used the $70.6 billion budget surplus and some tax and fee alterations to increase the 2024 and 2025 state budget from about $52 billion to approximately $72 billion. About $12 billion of that is one-time spending. So the legislature is now adjourned until February 12th of 2024, pending a special session, of course. The second half of the biennium is about a month shorter and referred to as a bonding year because there's usually a capital investment bill that year. However, there was both a bonding bill and a budget bill this year, and it wouldn't be abnormal to see a supplemental budget bill next year. Here you will see a list of the MMA's legislative priority items from this last session. The MMA board sets legislative priorities in the fall before the session. These were chosen as priorities to A, make Minnesota the best place to practice medicine, and B, of course, make Minnesota the healthiest state in the nation for our patients. We had a very good year as 4 out of our 5 legislative priorities ended up becoming law this year. The first one up there you will see was to extend audio-only telehealth coverage for another 2 years. At the beginning of this year, coverage for audio-only services was set to sunset in June. We were able to pass a bill extending reimbursement for telehealth services for 2 more years while MDH and DHS studies telehealth services and their effectiveness. The MMA does not believe that telehealth services are a replacement for in-person appointments, but they are appropriate and helpful for some patients. Specifically, we are hearing that audio-only services are working well for those who do not have access to video technology, may not be comfortable using video technology, and patients who may live far away from a clinic, think hundreds of miles in rural Minnesota. I anticipate that we will likely advocate for an elimination of the sunset altogether in 2025 after MDH and DHS study. Another priority for the MMA was to introduce CANDOR process in Minnesota. CANDOR stands for Communication and Optimal Resolution. It is used following adverse health events. CANDOR is meant to reduce the times where an adverse health event happens and for fear of litigation, the provider clams up and the patient becomes dissatisfied because nobody is reaching out to them. CANDOR creates a space where both bodies can come together to discuss what went wrong and come to a mutual agreement without needing to go to litigation. Patients are urged to have representation at these meetings, and at any point they can pull out to pursue litigation. But what we are seeing in other states is that have CANDOR, that most cases that go into CANDOR are resolved within that process. This passed this year and is effective for adverse events taking place on or after August 1st, so it started yesterday. Another priority for us involves POST, or Provider Orders for Life-Sustaining Treatment forms. These are forms for seriously ill individuals with limited time left to live. They outline treatment preferences and are very important to emergency medical providers. Currently, only paper copies of POST forms are available. We passed a law initiating the development of a statewide registry for POST forms so providers can access a patient's treatment preferences without having to worry about a paper copy being lost, damaged, or otherwise misplaced. The MMA board has recently taken up initiatives to address social drivers of health, one of which being homelessness. We passed a bill this year in partnership with Hennepin Health that would authorize coverage for recuperative care services, so people experiencing homelessness can have a place to properly recover after receiving treatment. Before this bill was passed, there was a concern that patients would come in, receive treatment, get discharged to the streets, and not fully recover due to unstable conditions, and then ultimately return with the same health conditions or health concerns. With this bill, there are now reimbursable services to help patients find stable housing to properly recover following their initial treatment. And then lastly, number 5 on there, we were regrettably unable to pass this into law. Our final priority involved mid-year formulary changes. Right now, an insurer or PBM can change the coverage formulary of a drug at any point within a patient's health insurance contract year. This can have negative health effects since many patients choose their health plan based on what drug it covers and cannot just switch to another treatment if the insurer alters their coverage. We wanted a law saying that an insurer cannot change their formulary for a patient who is already on that treatment until the end of their contract year. Essentially, if a patient is bound to the terms of a contract, we think that the insurer should too. However, as I noted, we were unable to get this bill across the finish line, but we will likely be pursuing this legislation in the future. Of course, those were not the only items that passed this year that the MMA worked on. It was an extremely productive and extremely active session. One item very relevant to this group probably is a bill legalizing the delivery and possession of drug paraphernalia. Minnesota became the first state in the nation to pass a law like this. The law also legalizes all forms of drug testing, allows syringe service providers to dispense sterile needles, and removes cap on the number of syringes a pharmacist can distribute without a prescription. This also went into effect yesterday on August 1st. Somewhat related, the legislature limited the sanction authority of the Opioid Prescribing Improvement Program, and legislators also voted to sunset the group in 2024, citing decreased opioid deaths by prescription drugs and with a more tilted focus towards fentanyl overdoses. Another top issue for the legislature was reproductive health. The first bill signed into law this year was the Protect Reproductive Options Act, or the PRO Act, which establishes the right to make autonomous decisions about reproductive health, including the right to an abortion in Minnesota law. In addition to adding the PRO Act language in Minnesota statute, the legislature also repealed existing statutes intended to restrict access to reproductive health services. The legislature also passed the Reproductive Freedom Defense Act, which offers legal protections to patients who travel to Minnesota for reproductive health services, including an abortion, from states where those services are currently or will soon be either limited or altogether illegal. This bill also offers legal protections to providers who offer those services to patients. Additionally, in the reproductive health world, the legislature authorized $1.1 million in sexual and reproductive health service grant funding and coverage for the insertion of long-acting reversible contraception postpartum. Another big issue for the MMA this year involved firearm safety legislation. One item we passed includes extreme risk protection orders, otherwise known as red flag laws. These allow a family member or law enforcement to petition a court to temporarily remove firearms from someone who is at risk of harming themselves or others. In other states, we see that these policies lead to decreased rates of violence and death by suicide. The other bill here is expanded background checks. We previously had background check laws in Minnesota, but what this does is expand on them to include private firearm sales and transfers and close the so-called gun show loophole so that people who should not have firearms cannot easily access them. Moving on, in the provider well-being space, the legislature passed a comprehensive paid family and medical leave program this year. This will require employers to offer up to 12 weeks of paid family leave and 12 weeks of sick leave, with a maximum combined total of 20 weeks per year. The program is funded through a 0.7% payroll tax increase. Employees will not receive their full wages during their leave. There is a formula as to how much employees will receive during their time off based on a typical work week and wages. I do not know the ins and outs of that formula, so I won't get into the exact details. But the intent of the bill was for most workers to retain 2/3 to 90% of their wages during their leave. The MMA also advocated for a ban of non-compete clauses in employment contracts. Non-compete clauses, otherwise known as restricted covenants, can severely reduce options for physician employment and negatively impacts the patient-physician relationship. This bill was authored by Senator and Dr. Elise Mann, a family medicine physician herself, and was adopted as part of the labor omnibus bill this year. So Minnesota law will now prohibit non-compete clauses in newly signed contracts as of July 1st of this year. Minnesota is one of several states to prohibit non-compete clauses. Unlike some states, though, there is no income threshold in Minnesota's law. So from the MMA's perspective, it should apply to most physician employment contracts. There are some exceptions to the ban on non-competes. The law will not prohibit non-compete clauses associated with the sale of business or a non-disclosure agreement. The law also states that an employee can be prohibited from accessing or using patient lists after leaving their employment, otherwise known as a non-solicitation agreement. Additionally, in the well-being space, we've seen a rise in violence against healthcare workers in recent years. So we put forward legislation and supported legislation of $4.4 million in grant funding to go to health systems to reduce violence in the healthcare setting. And then lastly, on there, we didn't see a whole lot in the workforce area this year. We pushed for robust physician loan forgiveness and additional rural residency funding. We were able to receive some primary care residency training grant funding and rural clinical training funding, but most of the healthcare workforce funding focused on other healthcare workers. I know this is a lot, but it was a very active legislative session, so just keep bearing with me here. So we saw some progressive health coverage related items passed this year, included expanded medical assistance coverage for undocumented Minnesotans, copay elimination for MA starting in January of 2024, easy enrollment in the MNsure program, updates to the all payer claims database, and a study into free primary care for all Minnesotans. I also included some early child items here since a bulk of the Health and Human Services Omnibus Bill spending included them. If you want to look at the really big winners from this last session, at least from a financial viewpoint, Minnesota's kids are definitely up there. In total, there are $1.2 billion of new investments in early childhood initiatives in the HHS bill, and that is not to mention $2.2 billion in an increase in K through 12 spending. To put all that in perspective, for those that work in the health space at least, all the health items that passed this year totaled $800 million. So this is an awful lot of spending. Some items passed this year include investments into early child programs, a new child tax credit, the creation of an entirely new department, the Department for Children, Youth, and Families, over $200 million in free school meals, and continued enrollment into public health programs for kids under the age of 6. Similarly to the Reproductive Freedom Defense Act, which I mentioned, the legislature also passed protections for providers offering gender-affirming care, as we are seeing Minnesota become an island in the region for offering those services too. And then lastly, we pushed for a ban of so-called conversion therapy on minors. The new law now bans the discredited practice aimed at changing an individual's sexual orientation or gender identity, and is currently effective for those under the age of 18 in Minnesota. So those were all the items that the MMA supported, pushed for, and passed this year. We were also able to work on and amend some items that we initially had some concerns with, and we're happy to say we got to a place that we were okay with what ultimately passed. The first is a proposed Minnesota Care buy-in program, or public option, which is to be implemented by 2027. There will be an actuarial and economic analysis on Minnesotans, on allowing Minnesotans to buy into Minnesota Care at a sliding scale with no cap on income. We had concerns with the potential reimbursement rates here, since typically MA rates are much lower. So if more people were covered by MA, some providers might not be able to stay in business. However, we were able to include provider reimbursement rates as one of the few but primary items to include in the economic analysis. Another item here is the Center for Healthcare Affordability. Originally, there was legislation to create a Healthcare Affordability Commission, which would have broad regulatory authority to collect data on healthcare spending and potentially issue fines of up to $500,000 to healthcare entities. We had serious concerns with the punitive nature of that group and the associated penalty authority, and worked with the legislature on what ultimately became the Center for Healthcare Affordability. The center will operate under the Minnesota Department of Health. Its role will be to collect healthcare spending data and conduct research and analyze drivers of healthcare spending. That center does not have the regulatory penalty authority, though it can issue a $500 per day late fee for data collection, though much of that data was already required by MDH before the law. Another item we're involved with that actually has some recent news on relates to expanded oversight of healthcare transactions and mergers. Specifically, this bill, now law, gives authority to the Attorney General to review and potentially pursue litigation over healthcare mergers involving entities with an average annual revenue of over $80 million. Entities with revenues between $10 and $80 million will be subject to the data collection through MDH. Part of the language that passed here also prohibits any out-of-state entity from owning the University of Minnesota Medical School and its hospital, which was pretty much, in my opinion, no secret, in direct response to the proposed Fairview-Sanford merger. It was since, I believe, last week announced that the Fairview and Sanford is no longer pursuing the merger and is not continuing with that process. And then lastly, on there, Minnesota, as many of you know, became the 23rd state to legalize adult use recreational cannabis. So recreational cannabis is now available to individuals over the age of 21 in Minnesota as of August 1st of this year, with retail being available in 2025. The MMA worked to include a requirement that a warning label be put on product packaging that includes information on the effects recreational cannabis can have on brain development up to age 25. There is also in the law strong enforcement against marketing towards children and prohibition of the presence of products on schools, which the MMA supported. Some tax revenue is also dedicated to addiction treatment and services, which is also something that we supported. So let's take a brief look at which bills didn't pass. As I mentioned, the mid-year formulary bill did not pass this year. We also did not see any major scope of practice bills this year. That is something I think we can expect next year in a non-budget year. We regrettably did not see anything on vaccinations. There is some funding for uninsured and underinsured adult vaccination programs, but language exempting children from public school immunization reports is still on the books in Minnesota. That is something that we at the MMA have pretty serious concerns with. We also introduced a prior auth data reporting bill that never really took off this session. Prior authorization is something that we are very interested in pursuing next year as a patient care issue. We want to make sure that our patients are receiving the care prescribed to them as quickly as possible. We also cannot spend as much time as we'd like with our patients if physicians are on the phone with their insurers all the time dealing with prior auth. On the firearm safety side, we were unable to pass safe storage requirements and mandatory reporting of lost or stolen firearms. These bills did receive committee hearings this year, but did not make it into the final public safety package. And then lastly, listed on there, the Keeping Nurses at the Bedside Act, which would require a predetermined percentage of nurses on hospital staffing committees, was slimmed down to exclude that language and only include nurse loan forgiveness and workplace safety language, which came to be known as the Nurse and Patient Safety Act. But going forward, here are a few dates that you should maybe put into your calendar now that the legislature is adjourned. They will return on February 12th of next year, 2024. Our Physicians' Day at the Capitol, and they say the Capitol is on February 28th, just before March 5th, which is the presidential primary in Minnesota, aka Super Tuesday. The legislature is set to adjourn sine die on May 20th of next year, and then the primary is on August 13th, and then the general election is on November 5th of next year. that is all I have for you right now. I know that maybe some more information than some of you wanted or needed today, but we have been working on an awful lot. This was a very active legislative session. So with that, I'd be happy to help answer any questions you have. Thank you.
Yeah, so several questions have come through in the chat, so we'll kind of run through those. One with the FMLA and the 12-week leave, because right now, a lot of people are having to use their PTO for that. So is that something that's not going to be needed to be used? And then does that apply to all healthcare workers?
It applies to all Minnesotans. So yes, and it is a state program that your employer opts into. Now, employers can have their own paid family and medical leave program if it meets the same standards, but my guess is that likely won't happen. I believe the implementation date for that is in 2026. I'm pretty sure in July of 2026. Might have to double check on that. I think that answered your question.
Yep. Kurt, you're muted, so I don't know if you're trying to ask a question.
Oh, I'm sorry. I was just making sure that you didn't have a follow-up to that. Okay, so there were some questions about telemed, and I think everybody's, as we came down to the wire, it was like, well, are we going to be able to continue doing some of the audio, video telemedicine? What is the MMA going to push for? Are they you were talking about pushing for it to just be continuous forever, right? Is that, what kind of support do you think that has?
Yeah, that is, can't speak for what we're going to do exactly in 2025, but we actually started out this session with a bill saying that we should just get rid of it forever. However, there is an ongoing study by MDH and DHS looking into the effectiveness of telehealth, which we have participated in. We've suggested other partners that they should work with on that. And then they will develop a recommendation to the legislature based on that study and report. I believe that study is funded through the next fiscal year, through July of next year, with the report being due in that 2025 legislative session, the next budget year. Hopefully, as part of that legislative recommendation, we will see a continuation of audio-only telehealth service coverage.
I can say I'm new. That's okay. I'm new to this meeting. I don't even know how I got invited, but I'm currently rural Minnesota. I was at Children's previously for child and adolescent psychiatry. I've taken a position in Hibbing, Minnesota, which had no child and adolescent services. So working as part of Mesabi Range. I have used telemedicine and specifically video a lot, and actually had 3 kids disclose sexual abuse by televideo, which I had previously thought that they had been abused, but it wasn't until COVID and we went to televideo that there were 3 separate families. My suspicion was, but I couldn't actually make them tell me. And so I have found such positive results with televideo in children and adolescents. And it scares me a bit to know that is going to go away, not because I have to go to the office to see patients, but because it has, I'm in the office every day here in Hibbing because a lot of people don't do telemedicine or televideo here. And I just got here 5 weeks ago. I've predominantly been seeing a lot of 3 to 5-year-olds with severe child abuse. In this area, there's not enough services in rural Minnesota. But my concern is if it goes away totally, that for a lot of our kids and teens, they are used to a screen. That is what they're used to. They are most comfortable on a screen. And if it goes away forever, that's just my concern. And to the 2 girls that disclosed on video, it was their grandfather that was abusing them. And I was able to get him charged and out of the home. The other boy had been sexually abused when he was 12, and it was beyond the ability to do anything with that one. But there are benefits that we don't even think about with our children and adolescents with telemedicine and televideo. I don't want audio only. Audio only gives me nothing with the child. Video gives me the most.
Kim, I love that you brought this point up, because I think, historically it's always great to be in the room with a patient because you can kind of feel the energy and the atmosphere, but especially as a child provider, adolescent provider, there is a big thing to be said for that. And, I think that's great information. And so for me, I think at least having that choice for patients to have that choice, because I think sometimes adolescents, like you mentioned, they're so used to the screen and they don't want that energy in the room where it's not a safe environment.
Right. Yeah. And they were 3 kids that I had seen multiple times in my office pre-COVID. I was 27 years at Children's and then just decided to come and open this clinic up here because of the need is so great up on the Iron Range. So I'm seeing a whole different load of problems, but I cannot let that pass me by as we're looking forward for video, especially for children and adolescents. It has been a huge impact in my practice.
And I with that would be kind of a question, Chad, is looking into the future, if there would be, rather than a blanket statement like all telemedicine is going away or it's going to be completely universal, like are there specific specialties or specific areas of the state, like if that would be a negotiating factor, like whether it's addiction versus mental health versus rural versus not, if those are different things you've all thought about.
Yeah.
I think that's something that comes into standards of practice, what is standard for a specific area. And I think those are somewhat established from my understanding, but the legislature could potentially reevaluate that when they discuss continuing coverage of audio-only telemedicine in 2025.
Yeah, I just noticed that all 3 of those senators, who I've met them all, are all in the Twin Cities area. So, there is differences in practice locations too.
Right. So Dr. Klein actually practices in Rochester, which I'm not sure if you consider.
Yeah.
I am still to learn what's out. So I lived in Hudson, Wisconsin. So I kind of had the Wisconsin side in terms of political, but I worked at Children's in St. Paul. And so I have yet to learn all the politics in this area and the school districts and all of that. And I'm in process, but as you can see, I still have boxes behind me. I've just started to move in. They actually found me an office finally. So that's been awesome. A good thing. So thank you so much.
Okay. Well, there's also a question about the no competes. And I clearly that's been something that's been things we've argued about for a long time. And there's somebody just asked whether or not the already signed non-competes, how do those get voided? Are we all to then go and do a different contract just to get an updated contract? Is that kind of what's being suggested? Or do you know how that works?
Yes. So it does not void contracts with non-compete clauses that were signed before the July 1 date. So those are still in effect. So it is effective. It voids those clauses signed on or after July. So it was the author's bill, I know Dr. Elise Mann, to encourage people to renegotiate or restart or renegotiate their contracts now, since that void would be in effect.
Wow, interesting. Yeah, it'd be interesting to ask if can I get a new contract? I'd like one. I think that's going to cause some issues, but
along with kind of the medical assistance and all of that, you kind of talked about expanding coverage, and this is being talked about at the federal level. There was just a news brief on this in terms of expanding it to include, the incarcerated populations. I think federally they're talking about Medicare will continue to cover, but any kind of medical assistance, min care for that typical dropped subset of patients.
I'm not aware of an effort there at a state level. There are no changes to current law, which from my understanding does offer coverage to that population. Again, that's at the state level. But there were no changes to that in this one. What it does expand on is it eliminates the copays, which is applicable to that population starting in 2024, and then undocumented Minnesotans as well as any children under the age of 6.
Perfect.
You know, there were some of the stuff you had in there, and of course, I think, you know, working in an addiction clinic, the whole marijuana issue is one that has been a little touchy. And actually, it's funny because I just got an email minutes ago before this started about, you know, what position we tell people we are in an addiction clinic as far as the use of marijuana. You know, you said something in there about the sales to youth. What exactly are they looking at for penalties now that this is so accessible when people are selling it to youth? Do you know, has that been changed drastically?
For penalties?
Yeah.
To use? I'm not sure of any changes in current penalties. I'm not aware of that, honestly. I know there is expungement for past cannabis-related crimes, immediate expungement, and then there is a process for violent criminal offenses to review for expungement. But I am not currently aware of any changes to current penalties. Okay. For me.
Looks like Charlie Reznikoff has a question. We're going to let him unmute. And if anybody else would like to unmute as well and ask a question, that'd be great.
Hey, this was great. I really appreciate it. And plus, I've been so busy. It's great to be back. You guys echo. I miss you guys, Kurt and Heather. My question is that anyone who's worked in or been in a hospital or emergency department lately, there is just an insane backup in our hospital systems, our emergency department systems. And it's just, emergency departments aren't fun. You know, they were never fun places to be, but it's really rough right now. If you need to be hospitalized, et cetera, waiting to be seen in the emergency department. The Recuperative Care Act is very welcome. I mean, my understanding is that's a great start at like unclogging the system. But I know that a lot of hospital doctors are really distressed about what's happening, where 20% or whatever hospital beds are just patients that don't have anywhere to go and are just sitting there, clogging everything up. Does the MMA or do you have any thoughts about what we can do to unclog the system, open up our emergency departments and get people moving out of the hospital?
Well, that's a huge question. Thanks for the question. That's something that continues to be a challenge for, I think, an awful lot of members, both in a patient care setting, putting the patients first and making sure they're getting the care they need and they're discharged properly, but also for the physician well-being and mental health, being able to adequately provide those services. So that is kind of why we're looking into a lot of the provider wellness and assistance there, trying to decrease violence against healthcare workers. But then also we consider prior authorization reform a patient safety issue. So, we don't have a patient sitting there waiting to get the meds that they were prescribed, and hopefully we can get their treatment promptly without spending a bunch of time on the phone with an insurer and then get them out the door with the service that they need. But I think that's a very comprehensive question that I don't think we really have one direct answer for, but something that we continue to battle.
Thank you. I guess I would just promote more nursing facilities, better pay for nurses, things like that. Thank you for your work.
Sam just asked a question. I'm going to piggyback on it. Insurance for mental health patients, one, trying to get inpatient mental health placement, but also addiction world, trying to, sometimes medical assistants will cover a month in inpatient, addiction treatment, which is not even kind of enough. And, there's loopholes sometimes but expanding that coverage to like the provider recommended time in treatment.
There are some expedited mental health coverages for MA that passed this year. You should probably ask NAMI about the details of those, not me, because I'm not extremely aware, but I want to double back to prior authorization. What we are looking for here, which might get those patients seen and treated faster, is maybe we exempt mental health services when it comes to prior authorization, and so we can fast track those patients faster. That's something that I think we're looking into. We're also looking for, let's say, if you have a chronic disease, that maybe you only get one prior authorization, then we require that you are never go through prior authorization as long as you're under that same treatment. So I think that's something that we certainly are interested in pursuing probably next legislative session.
Mm-hmm. Yeah, it's interesting because we actually had somebody on from Alaska, or I watched a talk from somebody in Alaska. In Alaska, they don't have prior authorization for a lot of the medications that we use in addiction. If you put it in, it goes through, and there is no waiting. And because waiting is often a death, right? When we're waiting for prior authorizations of meds. And although it's improved a little bit, if we make any changes, sometimes we're waiting for 4 or 5 days.
We're hearing that, we passed a pretty strong prior authorization law 2 years ago, one of the strongest in the country, but we're still hearing that it's getting much worse. So we're, again, looking at a lot of those creative ones. Is it that maybe we exempt cancer prior authorizations, because those are extremely time sensitive? You definitely can't wait for that. Maybe it's we devise certain codes that are exempt from prior authorization. So I know there's an awful lot of interest from probably this organization, the MMA, and other specialty societies to pursue something like that. I think that would likely be our top legislative priority going forward.
Yeah.
So with the paraphernalia bill and then the recreational cannabis bills, what is kind of the MMA's plan in terms of education, in terms of whether it's community, youth education, writer education? Is there a rollout plan for that?
We have regular, what we call forums, which are information-based events that we have once a month. I believe you get credit for attending those. I'm not sure if we have one planned for paraphernalia right now. Someone might correct me if they know of one like that, but it is something that we definitely want to keep our members and the public regularly informed about. Especially as we move forward, we might see decriminalization. And expanded that might be something that comes up next legislative session. I haven't heard a lot about that in my conversations with lawmakers, but that is something that I think could potentially be on the table.
Yeah, with the paraphernalia is huge, and a lot of it's just because the patients, whether or not they know about it, but it needs to be a safe place with providers. So providers need to be able to say, hey, this is a safe place if you have this on you, blah, blah, blah. And then I think the testing is important, and it's important for providers to understand that means forever. Patients are going to be able to test their drugs more than we can test their urine even, and to use that for an advantage as healthcare providers.
Right.
So, Chad, are there any other things that the MMA that kind of coming down the pipe that we should know? I mean, any other real priorities that you see kind of a ways out?
I don't want to keep touching on prior authorization, but that is definitely one where internally we want to be, I believe the quote was, disruptive or aggressive on some prior authorization reform. We're certainly going to, well, maybe not this year, depending on the financial situation of the state. We're interested in pursuing mid-year formularies still. I mentioned immunizations and vaccinations in my presentation. Right now on the books, you can have a personal exemption for vaccinations. And as we are seeing a rise in vaccine hesitancy since in the last 2 or 3 years or so, and rises of measles and mumps cases, that is something that we are certainly interested in pursuing. And then lastly, we have very, very substantial we passed a very substantial firearm safety legislation this year, something that, groups like the MMA and other groups have worked on for decades. But there are some holes, there's talks of a potential machine gun ban, but then what's the definition on that? Safe storage requirements, and requiring that ammunition and the firearms be stored separately, and then also mandated reporting of lost or stolen firearms. But we're also heading advocacy efforts, informing Minnesota's population about the seriousness of death by suicide related to firearms. Right now, it's the leading cause of firearm-related death in Minnesota, so we have other non-legislative advocacy efforts there that I think we're unrolling.
Can I ask a prior authorization question? Has anyone looked at the amount of time that it takes to order the medication, get it back, have to do the prior authorization, get the denial, the amount of time and power that it takes, not only the provider, but also our support staff. And I mean, I'm talking stimulants a lot of the time. Like, I'm not talking rocket science medications. Like, I cannot get a Vyvanse for a patient that's already tried Adderall, Ritalin, whatever. Like, I'm talking very simple medications, but it takes like 5 hours for my support staff to do a prior authorization for that. Has anyone looked at time response with prior authorizations and how that impacts what we're all doing?
So right now, based on the law that we passed, again, 2 or 3 years ago, there are some prior auth data requirements. Now that includes how many prior authorizations insurance receives, how many denials there are, how many are passed on appeals. I'm not sure if there are any time requirements in that. The issue that we are seeing is that, we require the payers to publish that data, but we have a very difficult time accessing that. They dig it deep in a website or somewhere and tuck it away. What we are interested in, which we actually drew up legislation last year that did not ultimately pass, is requiring them to submit that data to the state of Minnesota, probably the Department of Commerce or the Department of Health, and then maybe developing some legislative recommendations to examine that. I think timing is a very interesting one that we could look into too, because again, for a lot of these cases, prior authorization is all about time. So I appreciate the comment.
Yeah, it certainly in our world, in the addiction world, it has, we had a time where it was actually very good, where things had kind of gotten better, and now things are back kind of to where they were. And I don't know if everybody else kind of agrees with that. I think we're struggling more to get drugs this year than 2 years ago, which I find really amazing. And sometimes just switching simple things where we're going from Suboxone, which is a combo product, to a Subutex, which is a single product. It often is a rather urgent thing because a patient might be having side effects, but it may take us a day or two to actually make that happen. And again, these are lives that are at stake. And so I have been surprised by how much more difficult it's been this year than last. So just so the MMA is understanding, it got better for a while, but I think they're finding ways around making us jump through hoops. Sadly, I think Samantha, her note is, kind of explaining that they'll want you to try this, this, and this, and this. And I always tell the patients that the medications they get are basically decided not by somebody who knows the medications best. It's by a protocol that has been set up and really the insurance companies rule the world. So,
yeah.
We actually had a patient who they would kick back saying that they didn't meet this requirement, this one, whatever. And then we showed them proof that, nope, they met every requirement. And then they said, oh, well, now it's a quantity issue or it's a this issue. And I see the PAs daily, and it is probably worse than I've seen it in the last couple of years, saying that insurance just don't let us or let the providers prescribe what the patients actually need. And it's quite frustrating for us and the patients as well, too. So
I think, and I don't know, Samantha, if you know this one, but the most amazing prior auth question I have gotten multiple times now. We have an injectable Sublocade, Chad. It's Suboxone that's injectable, and you put it under the skin of the abdomen subcutaneously. And I did not document that the patient had not tried to remove that somehow with a knife, that I had not checked or documented that they had not tried to remove the injectable. And then for that reason, they wouldn't re-up the prior authorization. And I frankly have never seen that. I don't know if anybody has. I didn't know it was possible that you could remove that by cutting yourself and removing the medication. So
That's dangerous.
yeah.
It's not okay.
Dave, you look like you had a question.
There we go. Yeah, part of my biggest frustration is with the Adderall supply. You know, a patient calls up, they're on a 20, but the pharmacy only has 10, so you do 2 10s and then it gets rejected because it's a quantity issue. And there's just no flexibility on the part of the insurance companies, you know, recognition of reality.
Yeah. So I think what we're saying, Chad, is keep working on that one, because this one's got us all excited. So.
Well, you know, I mean, these stories are not atypical for what we're hearing right now, which is why it's becoming such a big issue. You know, part of our, you know, data requirements that we're looking into as well is not only do you have to report how many were denied, approved by appeal ultimately, but what are your reasons for denying it, and make sure that the state gets that information and can make some recommendations off of that. You know, is it because the physician's not dotting, or providers not dotting their I's, crossing their T's, or, you know, what are your top reasons, and maybe what are your top reasons for specific code or specific prior authorization would be interesting to know, because right now we don't have that information.
I think the quantity of months is huge. Like, I may want a kiddo on 7.5 milligrams, but I can't do that because then I need 45 a month instead of 30. So then I end up giving them more medication just to see if they'll tolerate the 10 versus the 7.5. And that's with a lot of meds in psych, not just stimulants. It's kind of crazy that I have to actually medicate according to what the insurance will give me.
Yeah, very true.
Or try medications for, 3 months instead of like, okay, well, most of the time, after about 6 weeks, if it's working, and nope, you try it for 3 months. Well, okay, well, now you're wasting patient's time, my time, and patient's not getting better. So, I mean, I can get a lot of data on what they're denying.
Yeah, I think part of it is stigma. I mean, when you look at, for instance, injectable birth controls or subcutaneous birth controls, I don't have to get a prior auth, and I don't have to say the patient didn't try and cut it out. But if somebody has addiction, I have to say that they didn't try and cut their medication out of their body. To me, some of that is also stigma, which I every time I get one of those, I just laugh. This is just the dumbest thing ever. So. Anne, you just showed your face. I'm wondering if you had a question.
I did have a comment. So I hear what you're all saying, and no, you don't really realize who I am, but I'm a health plan pharmacist and I do these decisions, but that is neither here nor there. A lot of people with substance abuse end up on medical assistance.
Yep.
And I've been fighting the fight forever to get all of the PAs removed, but the Drug Formulary Committee for the Minnesota DHS is the answer. If your voices are heard at their Drug Formulary Committee meetings, it would really help. It's been me, and they're sick of me. So I would support any of that. I mean, at our health plan, we've removed everything we can. And the local people around us who do substance abuse, they have my direct number to put in whatever Suboxone PAs or whatever. I also have tried to lobby for Minnesota Care, which is like the public medical assistance option. Their copays for Suboxone are $35. They can't afford that. So these are the pain points that I've had. And so if any of you want to submit public comment to the Drug Formulary Committee, that would be super great.
Is there any way you could send us how to do that and we could disseminate that?
I would love to.
Just send it to put it in the chat, and then Katie can copy it, and then we can maybe send that out to everybody. That'd be great. I really appreciate that comment very much.
No problem.
All right. I don't know. Has anybody else got any other questions? And we can take Chad off the hot seat. He has a lot of good information for us today. And Any other questions before we let him get back to maybe his late lunch?
Well, if they're not, I really, really appreciate the opportunity to present and take some questions and be part of this discussion. My contact information is very public. We have a website with my cell phone and my email. So if there are any other questions about anything legislative related or advocacy related, I am a nerd about that stuff. So please never hesitate to reach out to me about pretty much anything. So.
Perfect. And you can see in the chat that Juliana just put the MMA website. So. All right.
Well, thank you so much, Chad and Juliana, for helping connect us and everyone for these awesome questions.
Yeah, and thank you so much for Ann coming, and she's going to send us so that we can all call or all send in our complaint how things work at DHS. That'll be great. All right. Well, thanks again, everybody, and have a good week. And again, thanks so much, Chad.